Good afternoon, Mr. Chairman, ladies and gentlemen. My remit for this talk was branch repair of a thoracoabdominal aortic aneurysm. However, the angiographic movies within the presentations were making it very difficult to transmit this over Zoom, and therefore I have rapidly put together an alternative case of a complex aortoiliac aneurysm for ease of transmission. I hope you would find this equally useful. This is a gentleman who presented with quite an extensive aortoiliac aneurysm. More than this 3D rendering, these maximal intensity projections show the fact that this aneurysm is juxtarenal at the top in relation to the renal arteries, with quite a bilobed dumbbell-like bulge. And the aneurysm disease extends to both the common iliac arteries, as you can see in this picture. This is a line diagram of the outline. Here, this is the sagittal section showing the ostium of the right renal, here the SMA, and the celiac axis in its typical configuration. And the infrarenal neck rapidly dilating and unsuitable for use as a seal zone. And further, in the coronal sections, you can see that there is thrombus lining all the way up to the left renal artery, and there are thrombus-filled bilateral common iliac aneurysms. My plan, therefore, was to try and obtain seal and fixation at the top using a fenestrated endovascular repair, and preserve the left internal iliac artery using an iliac branch device in the left iliac system, but lose the right internal iliac artery by coil embolization. Loss of both the internal iliac arteries is generally well tolerated and a lot safer than people fear, but there are other disadvantages such as buttock claudication with bilateral loss of internal iliac artery. So, like every other complex aortic aneurysm repair, planning the stent graft is of great importance. So you spend a long time planning the device and having a discussion with the Cook company who provides these, one of the companies providing these custom-made devices. And the manufacturing center sends engineering diagrams and CAD diagrams such as these with centerline reconstructions on 3D workstations, giving exactly the device dimensions and other ancillary and additional implants that you're going to receive. Now, once you receive this and sign, you need to pay for this device, which can cost anything from £13,000 to £26,000 sterling. And therefore, and also this is the stent graft design that you're going to receive. Therefore, it is important that you check this against the native anatomy on a CT scan to make sure you can implement that. And once you're ready to do the repair, it's important to have a strategy as to how you're reducing the time of lower torso ischemia, because these are very long procedures. How do you reduce contrast-induced nephropathy, for example, keeping the patient well hydration, and how to reduce the general cardiac and other systemic complications risks. In thoracoabdominal aortic aneurysm repair, reduction of paraplegia risk is also a major issue, but it is a topic in itself. And after preparing the patient, this is the start of the operation. I started the operation by approaching the right internal iliac artery through the contralateral approach. I tend to take an 8 French 55 centimeter long sheath from the left groin into the right common iliac artery with a through and through Amplatz wire into the contralateral groin. This keeps the up and over sheath quite stable, through which you can do an eccentric puncture and send a 5 French catheter through, opacifying the internal iliac artery, cannulating that, confirming that you're in the right place, and then start putting coils in. The most frequently we use Cook Company's Nestor or MRI coils. It is important that the coils remain within the main stem of the internal iliac rather than to the branches, so that the branches can still communicate with each other to form collaterals from the transpelvic blood flow. And once the right internal iliac artery was occluded, I proceeded to introduce the iliac branch device into the left common iliac artery. This is the diagram and this is the photo of the device, and this is how it looks when it is introduced. The next step involves passing a through and through wire through the iliac branch device, snaring it from the contralateral side and bringing it out in the right groin. And then the iliac branch device is unconstrained up to opening of the internal iliac branch out. And at this stage, the through and through wire is used to track another, usually a 9 French Bolkin sheath over from the right common iliac artery through into the iliac branch, and through that sheath a 5 French catheter can be passed, and cannulation of the left internal iliac artery, which is the target of preservation, can actually be confirmed. So this is how the system looks now. This is the branch, internal iliac branch, into which there is usually a 10 French Bolkin sheath, and into which there is an eccentric guide wire, which is the through and through wire, and in the middle of this is the sheath carrying or a guiding catheter, or a catheter into the internal iliac artery. And then you track the target vessel stent quite frequently with Cook system. This is Atrium, Advanta Atrium, which is a balloon expandable stent with 2 layers of PTFE, and once that is placed into the internal iliac artery, the through wire is removed and the internal iliac artery branch is expanded, and deployment of the external iliac component is completed, followed by removal of the delivery system. And once that is done, you then introduce the fenestrated component from the right hand side, and this is how the fenestrated component looks, and this is the orientation of the side. These are the anteroposterior markers, the tick mark and the fenestration markers, and here are the weld marks. The coils you're seeing up here in the abdomen were from a splenic artery embolization that took place several years before he went in, and this has nothing to do with the procedure in hand. This is more information about the device you're implanting at this stage, and how each of the fenestrations look, and how the unconstrained device looks before it is packed away. These photographs actually belong to the device that we have implanted in the patient, taken before the manufacturers loaded them into the stent graft system. It is important to realize that these devices are very, very long, and they go into the arch of the aorta. Here you see a transesophageal echocardiography probe for cardiac output monitoring during the procedure, and also give additional information regarding the guide wire positions, etc. And here the fenestrated component is placed, and then it is unconstrained after confirming the longitudinal and circumferential orientation. And after unconstraining it like so, you proceed from within the stent graft to come out of the superior mesenteric artery fenestration and cannulate the SMA. And then a support wire is passed into the SMA. And in sequence, the right renal and the left renal artery are cannulated and confirmed, guide wires passed, and once the support wires are in the target vessel, appropriate Cook sheaths are tracked into the target vessels, and within these sheaths, target vessel stents are also tracked, position, everything confirmed, and at this stage, you are still seeing the anterior and the posterior markers and the check mark. At this stage, the next step would be to remove the diameter reducing wires of the device, which will result in unconstraining of the device, and the markers, you can see them, they have separated compared to when the diameter was constrained. And the top position once again is confirmed to make sure there is adequate amount of guide wire, and now the step of firing the top cap of the device, which is just gently pushed away from the fixation stent, and then that is retrieved by advancing the grey pusher central component of the delivery system, and then under vision gradually removed out. And then each of the target vessels or stents are deployed and flayed in sequence. And once all of the target vessel stents are deployed and flayed, it is worth doing check angiography for each of the vessels to make sure that there is no procedural iatrogenic injury such as a dissection or thrombosis or perforation. And once you are satisfied with all of those, you complete the endovascular repair, and this is a completion angiogram which shows all target vessels to be satisfactorily patent without an endoleak. To summarize, complex endovascular repairs, whether they are of aortoiliac system or thoracoabdominal branch repairs, they require meticulous planning of the device, and they require a big range of inventory of consumables and implantables, and you need to check them well in advance so that you know that you have them in stock. Always have a strategy as to what are the various elements of risk that we are giving our patient and how do we manage them through the procedure. These complex procedures sometimes can take quite long. 15, 16 years ago when we first started to do them, it used to be routinely the case that they used to take 7 or 8 years. Now, of course, with increased experience, we are able to do them in much shorter time, sometimes within as short as 3 or 4 hours of operating. But nevertheless, these operations can be long and intense. So you do need to be able to maintain concentration over long periods of time. You need to be in good physical and mental health. Leadership is important. It is important that the person leading the operation knows exactly the steps and the sequence and is able to lead the team through. And after every procedure is completed, it is a good idea to have a rewinding checklist just to make sure if there are any lessons that could be learned so that the next operation could be done safer and better. Just as I mentioned earlier on, the most important factors for successful complex aneurysm repair really is all about planning. Thank you very much for your attention.
Well, Dr. Khanna was another example of a complicated case, and he's very nicely taken us through this step by step, just to illustrate how he has done the case, and it was a nice example. I think we're not going to see another video from Dr. Vallabhaneni, but we're going to see next a video presentation from Algeria on the endovascular treatment of aortic coarctations, and that's the next video coming up.